All right, in this explainer, we're going to build a clinical toolkit for one of the world's most significant viral illnesses, dengue. For any medical trainee, really getting a handle on this disease is a frontline necessity, so let's just jump right into the central challenge. So, let's kick things off with a clinical paradox that every single provider needs to grasp. Why is it that with dengue, a second run in with the virus can be so much more severe than the first time around? It's a question that honestly shapes our entire approach to prevention and vaccination. And here's the answer. It all comes down to something called a secondary infection. See, dengue isn't just one virus. It actually has four distinct versions, or serotypes. Your first infection, it gives you lifelong immunity, but only to that specific type. The real danger comes later, if you get infected with a different serotype. That's what skyrockets the risk for severe disease. Seriously, this concept is the key to everything else we're going to talk about. So, here's our game plan. We'll start by unpacking that dangerous encore of a second infection. Then we'll start putting together our clinical toolkit, piece by piece. We'll cover prevention, the tricky situation with vaccines, and what to do on the front lines with treatment, before taking a quick peek at what's on the horizon. Okay, first up, let's really define the challenge here. To manage dengue, you have to get your head around two things. Its massive global scale and its unique, kind of counterintuitive immunology. Let's just start with the sheer scale of the problem. We're talking an estimated 390 million infections every single year. This is not some rare tropical disease. It is a global health powerhouse, and its footprint is only getting bigger. Now, this right here gets to the heart of that paradox we mentioned. After you get dengue the first time, your body makes antibodies. Great, right? They protect you for life, but only against that one serotype. For the other three, that protection is only temporary. And once it fades, those very same antibodies can do something totally unexpected. They can actually help a new, different dengue virus infect you, leading to a much higher risk of severe stuff like plasma leakage and shock. So when you're up against a virus that's this tricky, your first and best tool is just stopping it from happening in the first place. So let's look at how we build that first line of defense against the Aedes mosquito. The whole prevention strategy really rests on three main pillars. First, you've got to control the mosquito population itself. Second, there are personal measures, like repellents and screens. And third, there's the powerful, but as you'll see, very nuanced tool of vaccination, which we're going to dedicate a whole section to. And check this out. This shows just how innovative we're getting with mosquito control. One of the most exciting new strategies is releasing mosquitoes that are carrying a bacterium called Wolbachia. Now, this bacterium basically makes it way harder for the mosquito to pass on the dengue virus. A huge trial in Indonesia showed this strategy cut dengue cases by a staggering 77%. That's a total game changer. All right, now for what is maybe the most complex part of our toolkit, vaccination. Because of that whole risk from a second infection, trying to make a dengue vaccine that is safe and effective for literally everyone has been a massive scientific headache. So let's compare the two main vaccines out there. On the left, you have Dengvaxia, which was the first one to be licensed. The absolute crucial point here is its indication you should only give it to people who have already had dengue before. On the right is the newer one, Qdenga, which is approved no matter what your exposure history is. But, and this is a big but, its protection isn't even across the board, especially for people who've never had dengue. You'll also see that Dengvaxia is actually being phased out, and that's a direct result of all these complexities. This quote, which comes from the manufacturer's own analysis, really drives home the critical safety issue with Dengvaxia. If you give this vaccine to someone who's never had dengue, the vaccine itself basically acts like a first, silent infection. So if that person later gets bitten by a mosquito and infected for real, their body treats it as a second exposure, putting them at that higher risk for severe disease. This is exactly why you absolutely must test for prior infection before even thinking about giving Dengvaxia. And this chart just makes that risk crystal clear. For patients who've had dengue before, that's the bar on the left, the vaccine is highly protective. The hazard ratio is way down at 0.32. But now, look at the bar on the right for people who've never had it. Whoa. The hazard ratio jumps up to 1.75. That means the vaccine actually increased their risk of ending up in the hospital. It's just a stark visual reminder of why you have to know a patient's history. Okay, let's shift gears from prevention to treatment. What do we do when a patient walks in and you suspect dengue? Well, this part of the toolkit is all about being vigilant, monitoring closely, and providing really good supportive care.
First thing you have to understand, and this is absolutely critical, we have no magic bullet for dengue. There is no specific antiviral pill you can give. The entire focus of management is supportive care. And the single most important part of that is meticulous fluid management, just making sure the patient stays hydrated and their blood volume is stable.
To manage these patients well, you have to know the 3 phases of the illness like the back of your hand. It kicks off with the febrile, or fever phase. But the real danger zone, the part you have to watch like a hawk, is the critical phase. This phase usually starts right as the fever breaks, and it only lasts for about 24 to 48 hours. This is when plasma can start leaking out of the blood vessels, which can lead to shock. This is the period that demands our absolute highest level of vigilance. After that, they move into the recovery, or convalescent phase. So one of the first big decisions you have to make is who needs to be in the hospital and who can safely go home. This table is a pretty practical guide. If the patient has 0 warning signs, they're drinking fluids just fine, and their blood counts look stable, they can often be managed as an outpatient, as long as you have good follow-up. But if you see any of those warning signs, or if they have other medical problems, they have to be admitted, no question. And these are the warning signs you have to have burned into your brain. Stuff like really bad abdominal pain, vomiting that just won't stop, or any signs of bleeding. That last point is the classic lab finding you've got to recognize. Platelets are plummeting while the hematocrit is climbing. That rising hematocrit is a direct sign that plasma is leaking out of the blood vessels, making the blood thicker. It's a massive red alert for impending shock. Now, for a patient who is actually in shock, this is your core protocol. Step 1, an immediate bolus of an isotonic fluid like Ringer's lactate. Step 2 is constant reassessment. I mean it. You cannot just set the IV rate and walk away. You have to be at that bedside. Step 3, as they start to stabilize, you carefully, gradually taper the fluids down. And step 4 is just as crucial as step 1. You must stop the IV fluids once that 24 to 48 hour leak phase is over. If you don't, as their body starts reabsorbing all that leaked fluid, you'll push them into dangerous fluid overload. And finally, let's just take a quick look ahead. The toolkit we have for dengue isn't static. It's constantly evolving, with some really cool new therapies and vaccines in the pipeline. The future here is actually pretty promising. Researchers are working on direct-acting antivirals, like one called Mosnodenvir, that could one day be that specific therapy, that magic bullet that we don't have right now. And new vaccines, like the single-dose Butantan DV, are already in late-stage trials, which could give us much simpler and safer options for use around the world. So we'll end with this thought. Dengue is not a static threat. As our globe warms up and the mosquitoes that carry it expand their territory, more and more of the world is going to be at risk. And that forces us to ask, how do we adapt? How do we make our diagnostic tools, our preventative measures, and our treatments faster, smarter, and more accessible for a world where, for better or worse, dengue is an ever-growing reality?